Okay, so this is just kind of a recap on some of the things that we talked about already, how we're going to do our patient care. So we're always going to be concerned about our ABCs. When you come upon this patient and you notice bleeding, you're walking up to them, you can put your hand on them immediately to apply that direct pressure while you're asking them questions. What happened? What's going on? You're assessing your ABCs while you're doing that direct pressure. So you're going to make sure you control that bleeding. We want to make sure that we're giving them oxygen. If we need to splint, so I had mentioned that you might have a musculoskeletal injury, that splinting will help control that bleeding. Make sure that we are maintaining our patient's body temperature, and then get your patient ready for transport. If you think this is a patient that needs ALS care, make sure that you start your BLS care, but get that ALS team coming in right away. Okay, so on the left, you're going to see what I like to refer to as digital trauma. Your fingers are called your digits, and when you put it in your nose that far, it's going to cause some trauma. So there's some digital trauma for you. So epistasis is actually a nosebleed. A nosebleed can be caused by a variety of things, such as that digital trauma. Otherwise, it can be other types of trauma. It could just be dry air. But in some cases, these can be significant, and bleeding can last quite a while. So how are you going to control this nosebleed? You want to ask your patient to sit down. You're going to ask them to lean forward. Do not lean back. If your patient leans back, they're going to swallow that blood. It's going to make them throw up, and it's not going to help anything to stop that nosebleed. So ask them to sit down, lean forward. Ask them to apply direct pressure to the fleshy portion of the nostrils while they're leaning forward. We want to make sure that we keep them calm and quiet, and make sure they don't lean back. If this was caused by a trauma, our patient may become unconscious or able to control their own airway. If this happens, we want to make sure that we place the patient in the recovery position, which is on their side, and we want to make sure that we have our suction ready, because we may need to manage the airway for them. So while the picture is funny, shock is not. Shock is hypoperfusion, which shock and hypoperfusion both mean inadequate tissue perfusion. The result of untreated shock is death. What happens with shock is almost like a domino effect. When you have failure of one component of the system, the rest seem to follow. In early shock, the body tries to compensate for the blood loss. You might have signs and symptoms that the body is in this compensating mode. But shock can develop if the heart fails as a pump, the volume is lost, or the blood vessels dilate, creating that vascular container capacity that's too good to fill with the amount of blood available. Okay, so we know shock is hypoperfusion, which is simply inadequate tissue perfusion. There's decompensated shock and compensated shock. So we're going to start with compensated shock. So that the body senses that there's this decrease in perfusion and tries to compensate for it. For a while, the patient is able to maintain their blood pressure, but then the patient might start having an increased heart rate due to increased blood flow, and increased respirations due to increased oxygenation of the blood. The constriction starts of the peripheral circulation, and this is to kind of redirect the blood to the vital core organs. Your patient's going to now be pale. Skin is going to be cool. In infants and children, you're going to see an increase in the cap refill. So decompensated shock, now this begins at a point where the body can no longer keep up compensating for that low blood volume or that lack of perfusion. There's going to be some late signs of shock, so when you get into this decompensated stage, it's a late sign of shock. And those late signs are going to include a falling blood pressure, which is really significant. So you want to make sure that you're vitaling this patient frequently. So there's different types of shock, okay? Hypovolemic shock, which is most commonly what we see as EMTs and paramedics. It's also called hemorrhagic shock because that's when it's actually caused by uncontrolled bleeding, whether it's internal, external, or both. So again, if you break it down, you look at the word hypovolemic. Hypo we know is low. Volemic, we can look at volume, so we know that they have a low volume. Again, going back to the hemorrhagic, so we know it's a low volume in blood from some uncontrolled bleeding. Okay, so let's look at cardiogenic shock. Okay, this might develop in a patient that has myocardial infarction. It develops when there's inadequate pumping of the blood by the heart, or the strength of the heart's contractions might be decreased because of some sort of damage to the heart muscle. It also may occur because the heart's electrical system might be malfunctioning because the heart beats too slow, too fast, or just simply irregular. Other cardiac conditions can cause this problem as well. For example, congestive heart failure. All right, so neurogenic shock is something that we rarely see in the field, and it's a result of the uncontrolled dilation of blood vessels due to some sort of nerve paralysis caused by a spinal cord injury. Although there's really no actual blood loss, the dilation of the blood vessels increases and the circulatory system's capacity to the point where the available blood is no longer adequate enough to fill it. So again, we have that blood flow problem, that the blood vessels have dilated. We have the same amount of blood, but the vessel is too big for the amount of blood that we have. So it seems simple enough. What is poor perfusion? It's inadequate tissue perfusion. If we can find out what's causing the inadequate tissue perfusion, we can correct the problem. But again, we need to do some investigative work to find out what's happening. So remember, we have those three major categories of shock: hypovolemic shock, cardiogenic shock, and neurogenic shock. And if you look at the causes, trauma, heat stroke, blood loss, allergic reaction, a severe infection, poisoning, a severe burn, okay, it's going to fall under one of those particular three categories. All right, so patient assessment for our patient in shock. We want to look at the signs and symptoms. And one of the first things that we're going to notice is an altered mental status. They might be very anxious, they might be restless, or they might be combative. Their skin is going to change. It's going to be pale, cool, and clammy. For infants, we're going to see that cap refill time of greater than 2 seconds. And patients with neurogenic shock, which again is very rare pre-hospitally, they're going to have warm, flushed, and dry skin. And just as a reminder, I want to remind you that our PEDS patients will compensate for shock for quite a while, but once they are unable to compensate, they go right over a cliff. Adults kind of go downhill and we see that deteriorating. Okay, kids don't give us much of a warning there. Once they hit that point, they go right over the cliff and it's very hard to help them in any way. That's why it's so important that we notice the early signs and catch it early in the process. There might be nausea and vomiting, and we really want to make sure that we're looking at the vitals, because the vital signs are going to change maybe before we even notice some changes in our patient. So we're going to look at the pulse. The pulse is initially going to increase, and then it's going to become very weak and thready. The respirations are going to increase at first, and then they're going to become more rapid. They're going to be labored, they're going to be shallow, and sometimes they're going to be very irregular. When the blood pressure drops, that's a late sign. Okay, and again, remember, for infants and children, they can maintain a normal blood pressure up until half of their blood volume is gone, and at that point, they're near death. I'm not going to tell you not to use a pulse oximetry, but I just want you to know that it might not be very accurate in patients with shock. Other late signs of shock include thirst, dilated pupils, and sometimes you'll see some cyanosis around the lips and the nail bed. So our emergency care for this patient, the most significant treatment that you can do is that early recognition of the problem and get them to the hospital where they really need that definitive care. Every minute between the time of the injury and the patient getting to where they really need to go, which is ultimately surgery, the patient's chance of survival diminishes quickly. We haven't talked a lot about it, but we will in the upcoming weeks. The goal for our on-scene time when you're caring for a trauma or a shock patient is at max 10 minutes. Make sure that you're preventing heat loss. The condition can only deplete the body's energy, and that's not going to help the patient in their ability to clot. So if they lose their body heat, they're not going to be able to clot the blood the way they should. On scene, make sure that you are doing your ABCs, spinal precautions if necessary, a rapid trauma exam, a mobilization, and then move the patient to the ambulance. Make sure that you have an open airway and that you are assessing the respiratory rate. If the patient's breathing okay, then make sure that you apply high concentrated oxygen, so give them a non-rebreather. If they are not breathing adequately, then make sure that you are assisting in ventilations or performing CPR if necessary. Controlling external bleeding. Remember that if you attempt to stop this, that might be what's causing the problem. If there's a fracture, splint any suspected bone injury, because that again is going to help control the bleeding. You can splint the entire board by securing the patient to a long board. And again, remember, we want to protect our patient from that heat loss, so cover them with a blanket. We did that rapid initial trauma assessment when we were on scene. Now while we're in the back of the ambulance en route to the hospital, now we can perform a more detailed exam. If you think that it's necessary and you need an ALS rig, make sure that you do that. And again, calmly reassure your patient. If your patient's conscious and able to speak to you, talk to them, let them know what you're doing through the course of your assessment and your care, and relax them, because we don't want their fears to increase the body's work and develop and worsen the development of any shock. Okay, so once again, I have an assignment here for you. I would like you to take a look at the following questions, answer them by email to Kevin and I both, if you don't mind. Did you think I wasn't going to pop up in your video at some point through this whole process? So these are the questions I want you to answer, please. What are the 3 types of bleeding? What is a CAT, one that we use in EMS? What is shock? What types of shock are there? What's another name for shock? And what do you do for epistasis? And again, I just want to remind you, these are all crazy times for us. If you need something from Kevin or I, please reach out to us. We're kind of being creative and doing this as we move along here. So I'm just going to share some random funny thoughts with you. In this particular case, this is Rosie. This is my daughter's dog, who thinks that she should be helping Amanda teach her elementary school kids. So, and then just remember, Pocahontas said, sometimes the right path is not always the easiest. So this is the right path that we're on, is to continue the class, get you guys through it, get you the information you need so you can be successful in your national exam. If we can change a format, do something different, add something to it, please, again, let us know.